Hello, my name is Victoria McCredie. I'm from the University of Toronto, and I would like to thank the organisers for inviting me here today to talk about sedation in the neurological patient. I have no relevant disclosures or conflicts of interest in relation to this presentation. So the indications for sedation when I'm working in general ICU include a couple of general indications, and things that I usually think about sedation in general ICU is things like control of anxiety, pain and discomfort, agitation, and mechanical ventilation and dysynchrony. And those are all very relevant within the neurocritical care unit for our neurologically injured patients. But there's usually brain specific indications that I also consider, and those can be to reduce cerebral metabolic demand in the treatment of raised intracranial pressure, also for seizure control, and also to allow me to do targeted temperature management. And all of those summed up, I would say that sedation also has the added treatment effect for neuroprotection. And we think more closely about protecting the brain and thinking about using sedation as an agent for neuroprotection. I want to talk a little bit more about how sedation helps to reduce intracranial pressure. And so there's a number of ways, the first being that we think it helps with suppressing the cough and Valsalva, and in really trying to avoid any increases in intrathoracic pressure. Also thinking about reducing pain and agitation and any associated surge in your systemic pressures that may be transmitted to the brain. Thirdly, thinking about treating seizures that may be occurring in a range of our neurologically injured patients to try and reduce the burden of seizures and also reducing oxygen or the cerebral metabolic rate of oxygen and glucose and any metabolism mismatch that may be occurring, and to facilitate mechanical ventilation and for tight control of carbon dioxide. And finally, to think about reducing that cerebral metabolic rate to try and reduce our cerebral blood flow to overall reduce our cerebral blood volume and thus to reduce our intracranial pressure. And if we think more closely about, maybe some people think about it as intracranial compliance, but the correct term I would think is intracranial elastance, a change in pressure for a given change in volume. And really what we're trying to do here is, by sedation, trying to bring them back down that curve by reducing their cerebral blood volume, by dropping their cerebral blood flow, and also as well as changing our blood volume component, a component of their volume of brain tissue with swelling. There's also competing goals that I consider when I think about sedation in neurocritical care patients. And there is the offset of deeper sedation that we've talked about to try and control intracranial pressure, as well as reducing our cerebral metabolic rate of oxygen and glucose, to try and reduce shivering and associated systemic metabolic demands. And as we talked about in our general critical care patients, to address any symptoms of agitation, anxiety, and any vent dysynchrony, and also to suppress and prevent seizures. But the thing we have to weigh up and balance is the concern about thinking about a lighter sedation strategy. And that might be to minimize confounding post-targeted temperature management, as well as the frequent neurological assessment that we may want to perform in our patients to look for any neurological deterioration, as well as minimize any adverse events like hypotension and delirium, and overall to reduce delays in vent weaning and mobilization of our patients. So when I try and think about my one neuromonitoring tool that I have, which is my clinical exam, I know that sedation is going to get in the way of that and obscure it. If we look at some of the data about trying to wake up these patients, there is not much published, but some really great neuromonitoring studies by Skoglund and Raymond Hellbach looking at neurological wake-up tests, as we call it, and has consistently shown to induce a stress reaction in our neurologically injured patients. And this may involve increases in arterial blood pressure and heart rate that seems to also be associated with a transient rise in our intracranial pressure, and changes in our cerebral perfusion pressure due to this, as well as a change in the stress hormone profile. And there has been differential results looking at brain tissue oxygenation and cerebral microdialysis as we wake up our neurologically injured patients. So putting it all together, looking at the majority of studies that are out there, there's overall a low level of evidence. But when I look at them all together, I'd say about a third of them were unable to actually perform a neurological wake-up test due to concerns by clinicians due to high intracranial pressure, hemodynamic instability, and really trying to control intracranial pressure with sedation. And those that they try to wake up, about another third, it seems in practice we have to abort due to a rising intracranial pressure, agitation, systemic deterioration, or potentially respiratory distress. And then out of those that we do actually are able to examine here, when we hold our sedation, there seems to be actually a significant increase in the Glasgow Coma score in about 50%. So reassuring us that there's been no deterioration. There's a number of unanswered questions in this area, mainly to do with, does the clinical information obtained from the neurological wake-up test really justify the risk of the potential for metabolic stress and further neurological deterioration through that stress response? And does this really, the stress response that you might see every time that you wake patients up, mainly obtained through neuromonitoring, does this impact on long-term outcomes? And we don't really know. And with multimodal neuromonitoring becoming more readily available within larger academic centres, can we actually start to identify these clinically important deteriorations? For now, at least within my practice, the people I don't wake up or do holds of sedation, if I'm very concerned, is patients that I'm treating for intracranial hypertension or perfusion problems during targeted temperature management, or people that come in hyperthermic and I'm trying to cool them, patients who are in status epilepticus, and those who also have concurrent ARDS and systemic instability. Another effect that can have significant neurological complications or implications is the associated hypotension with sedation. And if we remind ourselves about autoregulation within the brain, where this is an example of intact cerebral autoregulation, where you have this plateau of autoregulation, and above and below that, we have a pressure passive collapse or pressure passive breakthrough. But we know that most of our patients in neuro ICU and some in our general ICU patients have a degree of cerebral dysautoregulation, and that lower limit of autoregulation is right shifted. And there's always a concern with hypotension that we actually drop our cerebral blood flow and precipitate ischemia. So when we think about sedation-related hypotension, the concerns I have are dropping our systemic vascular resistance, thus dropping our MAP and potentially our perfusion pressure. And if they have intact cerebral autoregulation, we would hope that that would kick in. And the concern, though, is that they might actually cerebral vasodilate to try and, within that plateau, increase perfusion to the brain, but also increase cerebral blood volume and potentially increase their ICP. For patients that have impaired cerebral autoregulation or are pressure impaired reactivity, we may see arterial collapse because that lower limit of autoregulation is right shifted. This overall causes a decrease in cerebral blood volume and could potentially decrease the ICP, but also precipitate cerebral ischemia. So thinking about sedation in neurocritical care, I always think, well, what agent might I give and how might I give it? Looking at studies, there isn't much evidence out there, but this is a paper by Roberts and colleagues looking at a systematic review of all randomized controlled trials. This is back from 2011, where they found overall 13 studies. There was 6 enrolled that had a very small number, less than 25 in those, and there was overall a moderate risk of bias within all of this. But when we pull out maybe some of the more used strategies, thinking about propofol versus midazolam, there overall was no difference in cerebral hemodynamics, but there was an adverse risk of increased triglycerides in the propofol group. If we think about another group like ketamine versus sulfentanyl, overall there was no difference there. And they also looked at propofol versus a morphine group, and overall no difference other than a decrease in ICP with propofol and an increased need for vasopressors in that group, most likely due to a drop in the blood pressure. There has been here is one study actually in cardiac arrest patients where by Paul and colleagues back in 2018, where they looked at propofol versus fentanyl after cardiac arrest. And they did a before and after. So before, they looked at midazolam versus a fentanyl, and they looked at the proportion of patients who either woke up and the time they woke up, or had the time to death or withdrawal without waking up, versus afterwards they implemented a propofol and remifentanil protocol, and they looked again at the delay from when they actually stopped the sedation and woke them up. And in both, you can see that the midazolam group took longer to overall wake up as opposed to the propofol group. And so the median time to wake up was 17 hours with midazolam and about 2.5 hours with propofol. So overall, within this study, they said that they saw much earlier awakening with propofol, more ventilator-free days, less use of catecholamines overall, but no change in survivorship or favorable neurological outcome at discharge. Looking at sedation protocols within neurocritical care, this is a paper by Egorod and colleagues in 2010, where they actually looked at the intervention of a protocol. By protocolizing the sedation in neurocritical care, overall, they found a significant reduction in the use of propofol agents and midazolam. They selected patients for daily interruption, and they found that those woke up faster, and overall those patients had less pain, and there was a significant increase in the analgesia used in that group. So overall, when I think about sedation in our neurological injured patients, rather than using the SAS score, I may consider these separate neurological conditions, and I might use a different target, but I would still use a targeted way of using sedation in neurocritical care patients. So overall, in summary, neuroprotection is the main goal that I think about when using sedation in neurocritical care. The important targets, always think about a specific goal, and always think about monitoring for side effects. And the titration and interruption of sedation, I think at this point needs to be balanced between the risk of interrupting and potentially exacerbating brain injury, but the potential benefits of an enhanced neurological function and reduced complications. So overall, I'd like to say thank you very much for allowing me this opportunity to talk to you today, and hopefully we were able to at least talk about some of the emerging concepts and concerns around sedation in neurocritical care.